Okay, good morning, good afternoon, good whatever time it is, if and when you're watching this. I'm Rob Leeper. I'm one of the trauma surgeons from Western, and we had a fantastic Zoom session for our CARMS applicants this past weekend. What was less fantastic was that we had maybe not the first, probably not the last COVID-19 era glitch in the CARMS process for all you guys and for us, which was a really inappropriate Zoom bomber who kind of poisoned the meeting a little bit. We worked through it, of course, and persisted, but one thing that Dr. Ott, our program director, thought was smart to do was to have me record some of the content that I gave on the weekend in a little more of a clean fashion without so much interference, so that people could look at that and access that at their own time, at their own leisure later on. And I have some questions that people asked that I'll answer on this recording as well. So it's a little bit more of a feeling of like a recorded Zoom session that you can look back on as you're going through the whole process and so forth. So without further ado, let me tell you a little bit more about why Western wants you and what it is about trauma and acute care surgery education at Western that I think makes it a special place to be. Okay, so there we go. During the Zoom, I was a bit more, maybe just post-Zoom, a little more sensitive about content, especially knowing this is going to be recorded and out there forever. So I wanted to make sure there's absolutely no implication of, breach of privacy here. So I've taken a couple of the key images that were up during the talk out. So what we had here was a cool image of a sternotomy I did for a low carotid injury, a cool image of a ED thoracotomy we did that had a survivorship, and this is the one image I kept up there is a cool picture of John Landau, one of our colleagues and partners in ICU, putting in a Roboa and with me. And the point of the slide, the next couple, was to say that, London actually, and Western is we're not the busiest trauma center in Canada or North America. I'll give you some more slides on that later on. But we're not quiet either. This is a picture that is pretty safe, I think, to show. It's, just an example of, and it's just a couple that were on my slide deck in the last year. It's a really interesting pancreatic injury we had. A cool sort of injury right at the neck on top of portal vein, where we did a nice sort of, splenic preserving distal pancreas case. So it's a really, another really neat trauma case that you get to see and do and be a part of here in London. I have a slide here that I took one picture out, but the other feet were still intact. A couple where this was just a really recent case of a stab wound to the left quadrant, showing a diaphragmatic injury, a lung injury, a through and through splenic injury, and then a through and through gastric injury. So a very classic, typical penetrating knife wound that you'll see plenty of here in London. This last one was quite an impressive blunt trauma case that, again, I'm sorry I removed, just to be sort of super safe and super thoughtful about not putting up images on the internet that are there forever. But again, just highlighting the fact that you don't come to London because we're LA County or we're Cook County. We're not the world's busiest trauma center, but we're still plenty busy, and there's still plenty of clinical work to do and to experience from a trauma and certainly an acute care point of view. But that's not actually what makes us unique. What makes us unique is how we do things a bit differently, not just from other places, but from what the reality was across the history of teaching people how to do trauma and acute care surgery. You see, this is a guy named William Stewart Halstead who, I did my fellowship at Johns Hopkins, and he's a guy who was rightfully, worshipped and revered, and his system of training, this see one, do one, teach one, is exactly how, surgeons in North America and the world over have been trained for 125 years or so. And there's only a few things wrong with that, and it's that it doesn't imply or it doesn't impart the ability to really gain a level of competence, let alone expertise, before you're doing work on patients. And that can be anxiety provoking for learners and providers, and also not the best patient care. So in the year 2020, what we've done here at Western is just reshuffled this already time honored tradition and said that we're going to put the do one ahead of the see one and repeat and repeat and repeat until you get it right. And that's what sort of I've replaced Dr. Halstead with Dr. Leslie, our chief of surgery here, because for us, I want you guys, as you're learning to do good trauma care and acute care, to be doing one, seeing one, and then repeating it over and over again. Within and before you're actually in a spot to have to do that in real life. And what I mean by that is I'm talking about our trauma simulation curriculum. And so this is a little overview of that curriculum. What we've done at Western over the last 5 or 6 years is created a curriculum based on high fidelity simulation of trauma scenarios. When you come to Western, a bit like the sorting hat on your first day at Hogwarts, we're going to assign you to a team, one of 5 teams. They're color coordinated. I buy them all scrubs each year, and you get the handshake like you've been drafted into each team. The teams are named after 5 of our founding sort of trauma surgeons in the history of surgery at Western. Team McLaughlin, Team Duff, Team Holiday, etc. And they each have their own logo and their own sort of motto. And when you're on that team, you stay in that team for life. From your first year, second year, third year, fourth year, fifth year, you graduate up the ranks, and as the 5th years leave, a new first year comes in. And those teams participate in simulation activities throughout the year. We do 4 trauma sims per team per year, so you do a total of 20 over the course of your training here, and we give you feedback in the real time, in the moment, right after the sim, but also we like to give report cards back. So we'll analyze the video and audio recordings, and we'll rank you guys. Say, hey, your team was the best at this behavior, this objective, or the worst at that behavior, that objective, so you can see where your team performance lies, whether you're doing really well compared to your peers or need to improve. And the nice thing is we make the other team's status unknown to you. You know how your team fared, but you don't know where the other 4 teams ranked, making it anonymous and safe that way. No one should feel badly because all you have to know is what your own goals are to improve. This is a screenshot of just kind of a typical day. You can see we have a picture-in-picture with a couple of GoPro cameras in the room, and this happens to be Team McLaughlin there in the background in their blues. I'm in the sim as a Confederate running it, and they're working on, I think this was a stab wound to the neck, if I remember correctly. And so it's really an interesting, powerful, sort of fidelitous way to learn trauma care in a safe and supportive environment that gives you high quality feedback, and that makes you a really, really effective and able participant when you're in the trauma bay and in the operating room taking care of injured patients. This is just a slide with a couple of some press the program has gotten in the local kind of Western news. That's the presentation we did at a meeting and a publication just based on the first year of our data. And this is an educational research paper in a decent journal of surgical education, published by myself, of course, and by one of our newly minted PGY2s, Nick Matreau. So just to show you that it's a good curriculum, it's recognized nationally, and that there's an opportunity not just to participate in the learning and the education, but also to participate in educational research as a young trainee. Nick did this work as a PGY1, so it's a lot of good stuff, and I think a curriculum that we are really proud of. It's unquestionably the most involved simulation curriculum in Canada, almost certainly in North America for trauma care, and I think it's the best, actually, that there is to be offered out there in surgical training. So that, I think, is the feather in our cap. That is what makes London and Western a cool place to train from the point of view of trauma and acute care surgery, is that it's not just relying on clinical volume. We have that, but what you get in addition to that is a really amazing experience from an education and simulation point of view in your training. Okay. And that's just sort of what I just said, but in text format. So at this point in the talk, I shifted over to Kelly. She got in her a bit on research before the infamous Zoom bomber 2020 joined our ranks. And then I didn't get a chance to go back and do a lot of the questions. So I'll do those now. I shouldn't take too long. I'll just go through the 4 or 5 faculty questions that we were asked that I was able to put some slides together and answer for you. So again, these are the questions we were asked. I think, truthfully, if you look at, the sim stuff, that was all really answered in the last 9 minutes of me talking. So that should be easy to figure out. Research, again, that went through Kelly. So you can reach out to her for answers there. And the residents answered a lot of their questions as we went, but I will tackle these faculty questions here in this format, so you have those to kind of look back on going forward. So, okay, so one question we got was how involved junior residents are in trauma and acute care, and I think it's pretty involved. If you think about it, you'll as a junior resident have 2 blocks dedicated on the trauma service. That means that, your daytime is spent rounding on the trauma patients, looking after them, and responding to any daytime trauma calls. And at night, you carry the pager. You're the trauma resident on call. So for 2 months in a row there, you're doing 1 in 4, 1 in 6 call for trauma, and getting to really experience the kind of in the moment frontline trauma events. Additionally, because you have 6 months of surgery, 3 of which are at Victoria Hospital, and a lot of those are on the ACS team, you're going to spend probably another good 3 blocks carrying the pager at night for trauma, because all of our junior residents on surgery go to the traumas. And on the ACS team, you're the ones responsible. Your consultant is the trauma consultant of the day and the night. You'll be taking care of a lot of trauma patients, operating on them, take backs for various, trauma issues, all through the time there. So really, you'll probably get at least 5 good months of pretty involved trauma care as a first year. In second year, you'll do 2 blocks of ICU, and that's ICU here at Victoria Hospital at our critical care trauma center. So during the day, you're looking after the sickest of the trauma patients on the ventilators in the ICUs, and at night, again, you're part of the trauma team. You go to all the trauma activations. So really, by the end of your first 2 years, the junior years, you've probably had, 2, so 5, 6, so 7 blocks, 7 months of trauma. More than a quarter of your first years are spent really in a pretty dedicated role caring for trauma patients. This is a funny one. Somebody asked, and I think importantly so, what is the division of responsibility between the emergency medicine division, and surgery from a trauma care point of view, i.e., and I put it in red, do you only take over after the CAT scan? This is the picture of the hands on hips, unhappy meme at that question, because no, of course that would be, hey, listen, there are times when a very minor, bicycle crash happens and EM might scan the patient and call us, hey, we were surprised, we thought that guy's going to go home, but it turns out he has a rib fracture and a femur and he can't go home, can you come see him? Sure. That certainly occurs. We call those traumettes. But for real trauma, big trauma, bad trauma, comes in by helicopter, by orange, with stab wounds or gunshot wounds or, high velocity stuff. For real trauma, guys, I'm going to use a very cheesy prequel meme, but this is the exact way you need to think and understand. This is Palpatine is saying, "I am the trauma." We are the trauma. We are the trauma surgeons. We are the ones looking after these patients. These are our patients, and I'll tell you a bit more about that. What I mean by that. So for sure, just to be really specific, any major trauma, as in not a trauma but a serious activation, and this is the criteria for us to activate any trauma team activation, requires the presence of the following sort of group of people. You're going to have a trauma team leader, who I looked at last month's call schedule, and a little more than half, 55% of the call group, are general surgeons. You'll have a surgery senior resident and a surgery junior resident, who are of course surgeons. You'll have an ICU junior, who about half of those at Vic are going to be surgeons. The other half are anesthesia and emerge. And then you'll have an anesthesia resident who's not a surgeon, and a trauma junior resident who is by and large a surgical resident. So really the entire trauma team is heavily surgery driven. The TTLs, about half of them are surgeons, and ultimately they are on this list, but the trauma surgeon is the on-call general surgeon, one of us. We are the ultimate person who's responsible for the operative care of these patients, and so absolutely we are involved from before they get there, and then the best run traumas are run because a trauma surgeon and their EM colleagues are there with all the whole trauma team in their PPE, prepped up, ready to rock and roll, ready to look after a trauma patient as a team before they arrive, when we have the heads up about an incoming trauma or whatever else. So no, we absolutely are heavily involved in trauma care in all aspects of it. There's nobody better suited to care for a trauma patient than one of our trauma surgeons. I promise you that. This is a good question. So somebody asked, what does a day look like as a trauma surgeon at Vic? And so I have to do a little explaining again on that. So the general surgeons at Vic are the trauma surgeons. When we're on call at night, or at night it's on call, or during the day as an access surgeon, you're the trauma surgeon. And at Vic we have sort of three general categories of surgeons. We have surgical oncologists who do breast and sarcoma and melanoma and stuff. We have colorectal surgeons, and we have ACS trauma surgeons. And so any of the three of us who are on call at night or during the day are going to be running our usual practice. In the daytime, we're running a busy access OR, and I'll talk more about that later. At night, we're on call. And it's the same as any other day of surgery, except that when you're the trauma surgeon on call at Victoria Hospital, you need to have nothing going on that you can't walk away from in 30 seconds flat if you feel the heat coming up from Emerge. And this is a quote, of course, from the classic film Heat. And what I mean by that is trauma calls like any other call, except you're never more than a split second away from something really big and really serious coming in. And I love that about it. And all of our surgeons who I work with, all like the 9 or so of us that work together, love that, because it really does inspire us to be always on our toes and ready for the next big thing to come through the door. And that's what makes calls so much fun here. Okay, this is an important slide. And again, the data is from my own kind of head and from my own anecdotal experience looking at it across Canada. And so please don't shoot me if the numbers aren't exactly right, but I tried to help you guys understand what a busy versus a moderate versus a more quiet level 1 or lead trauma university hospital would look like in Canada. And so this is just a map of the major universities that support trauma care in the English-speaking sort of side of the Karma's match. And you can see, I think, the busiest places, your Foothills, your VGH, Montreal General, and the 2 Toronto hospitals are in red here. And I think London is not as busy as Sunnybrook or Foothills, no question about it. But we would be in the kind of middle of the road category. They're with Hamilton and Ottawa. They're with the 2 hospitals that kind of share trauma at Edmonton. We'd be a very much a medium volume center. And so we see about between 300 and 500 major traumas per year with an Angers Fair score above 16, and then another couple hundred less severe traumettes or ISS less than 16. So I think, like I said, if you really just want to have a fill your boots clinical, deluge of trauma, apply to LA County. There are lots of great places you can go to just see pure clinical trauma, and then they're phenomenal. Don't get me wrong. Baltimore, where I trained, was amazing. But I think if there's a huge benefit to training in Canada, and among Canadian centers, we are a really high-performing medium volume center, and I don't think you'll have any kind of challenge leaving London as a very well-trained trauma and acute care surgeon and getting an awesome fellowship anywhere you want to go to pursue your work thereafter. Okay, one other question, that might be my last slide, that somebody asked was about case volume at Western compared to other places. And so I thought I'd get real with you. I pulled my my case log. This is my case log from residency, which again is a couple years old now, I'll give you. So it would be different than what yours would be. And in fact, I think that yours might be more than mine because I didn't have the access service for all of my last year in 5th year. And I took a year off to do ICU during residency. So this is only 4 years for me. And I did, as you can see, a good number of all of the kind of index operations of general surgery. Looks like lap chole was my #1 operation, but, neck and neck with colonoscopy, actually. And X-laps and X-thoras, about 70. But again, a lot of those were not for trauma. They were for other causes. It's hard to break that down with the way our coding used to be done. So I mean, and a total of, I think, 1,905 cases in my 5 years, which again was only 4 because I had a research year in there, or an ICU rather. So I would just say to you that Western's a really busy center. You'll do a lot of operating here. I think you can ask anybody you like and say, hey, where do you think could be the biggest volume and highest quantity and quality of operative training in Canada? And they're all going to just say Western. I don't think anyone's even going to fib about that. It's us. We are a very, very busy center. We do a lot of great work. And I'll tell you, it's my last slide, so I'll kind of just wrap it up here. But I don't think that our busyness and the work we do is destructive to your life or your pattern of your way of living. And a big reason that that's true is because of what we've done with the access service. So as you may or may not know, we have, and we're one of the few places in Canada that has, 8 a.m. to 4 p.m. access room every single day of the week at Victoria Hospital, so that we can put all of these acute appies and choles in, and other cases into that room and focus the efforts there, so that you get, lower, maybe acuity, lower complexity, I should say, cases in a busy service that you can come into and come onto for maybe you're a month or 2 or 3 as a resident. And then when you're off that service, sure, it's a busy time. No question about it. We change staff people every week on that service. It's a busy service, but when you're on the other services, you're protected. So on your HPB, your colorectal, your surgery oncology rotations, you're protected from the deluge of consults, from the daily ward calls, from all that stuff that would drag you down and keep you late. And you can just focus on those kind of maybe boutique operative experiences. So it really, having what we have with this protected access time, it's a brilliant way to get your experience and your exposure. And then also it's a brilliant way to protect, your time elsewhere in residency. And so I think it's a really exciting, really, I think the best setup for learning surgery anywhere in Canada. I love it as a resident. I came back here to work as a staff for that reason, among others. And I think you guys would love it here too. It's a great place to learn surgery and a great place to learn trauma and acute care surgery, thanks to some of the educational work that we're doing here. So again, any questions at all, please reach out to me. I'm easy to find on email, rob.leeper.sc, or on Twitter, rob_leeper. If you want to just tweet at me, would be awesome. All right, thanks so much for your attention, guys. A bit of a longer one, 20 minutes, sorry. But that is what I came to say on the weekend before we were so rudely bombed on Zoom. And again, I look forward to meeting all you guys virtually throughout the course of this CARMS process, and to matching 5 amazing girls and guys out of this category, out of this group, come March, and to meet you in person in July. All right, take care.